Welcome back to the What's in Your Head podcast. I'm Pete Schultz, doctor of physical therapy. If you're new to the podcast, welcome. My goal here is to help you better understand pain, dizziness, concussion, headaches, and the nervous system by combining the latest evidence with practical strategies you can use in everyday life. Today's episode is all about Ehlers-Danlos Syndrome, hypermobility, and why being too flexible isn't always an advantage. Many people have been told that they have Ehlers-Danlos Syndrome, or maybe they simply know they're unusually flexible. Some have experienced years of joint pain, repeated strains, headache, dizziness, fatigue, or injuries, and wonder if it's all connected. Today we'll answer questions like, what exactly is Ehlers-Danlos Syndrome? What's the difference between EDS and Hypermobility Spectrum Disorder? Why do some flexible people have no pain while others struggle with persistent symptoms? And most importantly, what does the research tell us and how to manage these conditions and still stay active? Whether you've recently been diagnosed, think you might be hypermobile, or you're a healthcare provider trying to better understand these conditions, I hope you'll all come away with a better understanding and some practical tools to help. Before we get started, a quick reminder that this podcast is for educational purposes only and should not be considered medical advice or a substitute for an evaluation by your healthcare provider. Every person is different and treatment should always be individualized. If you're experiencing new, worsening, or concerning symptoms, please consult your physician or another healthcare professional. What is Ehlers-Danlos Syndrome, or EDS? I may be referring to it as EDS sometimes throughout this podcast episode, and sometimes I'll call it Ehlers-Danlos Syndrome. They'll be interchangeable. Ehlers-Danlos is actually a group of inherited connective tissue disorders. So there is a genetic component to EDS. Connective tissue is found throughout your body. It provides support to your ligaments, tendons, skin, blood vessels, and all your other tissues. One of the primary building blocks of connective tissue is collagen. If collagen isn't formed or it functions normally, the tissues could become more elastic and less supportive. As a result, joints may move further than intended, making them less stable and requiring the muscles to work harder and control movement. Fascia, which surrounds a connective tissue that surrounds and supports all muscles and actually all structures in the body, the function of fascia is to provide structure. When fascia is loose, it leads to a lot of issues within your muscles, tendons, joints, and internal organs. Fascia is that connective tissue that basically, when I think about fascia, it's the connective tissue between your skin and your muscle. If you ever peeled the skin off a chicken or something like that, and you see that white connective tissue in between the skin and the muscle, that's fascia. But fascia is not only in between the skin and the muscle. Fascia runs in between all the muscles, and fascia is found in between your muscles and your bone. Fascia is also found in between your intestines and your internal organs. Fascia is the structure in the body that holds everything together. With people with EDS, they have looseness or more elasticity to their fascia, but it's not really holding or it's not really stabilizing. And that's not only with EDS or Ehlers-Danlos syndrome, it's also anyone with hypermobility. Hypermobility is basically a syndrome that causes the fascia to be more loose than it's supposed to be. There are several types of EDS. Ehlers-Danlos syndrome has 13 subtypes. The most common one is EDS hypermobility. Hypermobility EDS, or HEDS, is where you have increased elasticity and you have looseness or hypermobility in your fascia or in your joints and ligaments. The other types of EDS are classical EDS and vascular EDS, and then there's a bunch of other rare types. Now, the interesting thing here is that hypermobility EDS is the most common one by far, yet there's no real genetic marker to hypermobile EDS. All the other ones have a genetic component, and it's thought to be that all of Ehlers-Danlos syndromes, all of the subtypes have a genetic component. There is a genetic component and genetic testing to identify part of the process of diagnosing Ehlers-Danlos. That comes to how is Ehlers-Danlos diagnosed? So there's no single test for Ehlers-Danlos. No genetic or laboratory test currently confirms the hypermobile EDS. The diagnosis is based on history and a physical examination. Remember, this is talking about the hypermobile EDS. Some of the other subtypes do have genetic testing and genetic markers for diagnosing that. The current diagnostic criteria that was established in 2017, which is being reworked right now, and currently the new diagnostic criteria should be coming out this year. One is generalized joint hypermobility. Joint hypermobility is assessed using something called the 9-point Beighton laxity score. So that is a bunch of tests on different joint positions showing that these joints are more flexible. We use this Beighton score to see if people have hypermobility. Some additional features of hypermobile EDS are skin changes, chronic musculoskeletal pain, recurrent dislocations or subluxations of joints, and other characteristic connective tissue features. So when we're diagnosing EDS, we also have to rule out other conditions. So when you're diagnosing hypermobile EDS, we're trying to rule out the other types of EDS. We could rule those out through blood testing. We're trying to rule out things like Marfan syndrome, other autoimmune connective tissue disorders, and other conditions that might cause joint hypermobility. Well, hypermobility does not automatically mean that you have EDS. Many people are naturally hypermobile, and symptomatic hypermobility does not mean you have hypermobile EDS. And people who do not meet the criteria for hypermobile EDS have something called Hypermobility Spectrum Disorder, or HSD. Oh, Hypermobility Spectrum Disorder is just like it says. It's for people that are found to be extremely hypermobile, may have subluxation in joints, but they don't meet all the current diagnostic criteria for Ehlers-Danlos. Like I said before, the 2017 criteria remains the current standard, but it's currently being revised, and the new diagnostic criteria will be coming out, and it's expected to come out later this year. Today, since hypermobile EDS is the most common type of EDS, we're going to focus the podcast today on hypermobile EDS. And it is the most common one that I see as well. Now, it's important to understand that whether you have hypermobile EDS or you have hypermobility spectrum disorder, the treatment is relatively the same. We're going to go into all the treatment and the recommendations that I would currently do with a client that comes in with EDS. From a physical therapy standpoint, whether you're diagnosed with hypermobility EDS or hypermobility spectrum disorder, the treatment is going to be basically the same. Is hypermobility always a problem? And the answer is no. Many dancers, gymnasts, swimmers, yoga practitioners are naturally hypermobile, and they're fine. They don't have chronic pain. They don't have issues where they're subluxing. Yes, they're more flexible than the normal population, but they don't necessarily have to seek medical care. They don't necessarily have conditions because of their hypermobility. That being said, flexibility alone is not a disease. Problems start to arise when increased mobility or increased flexibility exceeds the body's ability to control it. Think of it like driving a sports car. You're driving a car that has really loose steering. If you're in a car that has a really loose steering wheel, really sensitive steering, the car still works fine, but it takes more effort to keep it going exactly where you want it to go because that steering wheel is wobbling all over the place. Your muscles become like the steering system, the thing that keeps your car on the road. And if those muscles fatigue, the joints get really sore and painful because they're working really hard trying to control that steering wheel. Now, let's talk about some of the common symptoms that we see with people with hypermobile EDS or hypermobility spectrum disorder. Some of these symptoms that we see are joint pain, frequent ankle sprains, shoulder instability, kneecap or patella instability, hip pain, neck pain, jaw dysfunction, TMJ dysfunction, back pain. And other symptoms might even include fatigue, headache, increased migraines, increased dizziness, lightheadedness, digestive issues, cardiovascular issues, issues with your heart valves, easy bruising. Sometimes people wake up with bruises all over their body, or you bang into something that you didn't realize, and pelvic floor dysfunction. Some individuals also have POTS, which is postural orthostatic tachycardic syndrome, which can cause dizziness, rapid heart rate, and exercise intolerance. Not everyone who has hypermobile EDS experiences every single symptom, and the severity obviously varies widely from person to person. And again, looking at these, they're not only musculoskeletal problems. These are musculoskeletal problems, and they're also systemic problems, because when we think about connective tissue, the connective tissue that's hypermobile, or that loose connective tissue, surrounds the whole entire body. With that, the collagen and connective tissue makes up heart valves, and it makes up the connective tissue that's in between intestines and wraps around muscles. We get musculoskeletal issues as well as other systemic issues with EDS. Okay, now my favorite part, why does this hurt? Sometimes people with hypermobility or EDS have pain, and sometimes they don't always have pain. One of the biggest misconceptions is that pain is caused only by the loose ligaments, and this looseness of your ligaments is driving all the pain. But the truth, it's more complicated, right? When the joints move further than they're supposed to, the muscles have to work a lot harder to stabilize. And when the muscles work harder to stabilize, they get sore. And sometimes you have sore muscles. Sometimes when those muscles are working really hard, the tendons get irritated and you get tendonitis in there. And these small muscles that get really sore are going to be irritated. And that's the concept with sore muscles. But now when this pain becomes persistent and you have this long-standing pain, now we have to talk about the nervous system, right? Over time, the nervous system is going to become more protective. And we know that the pain in the nervous system is an output. Pain is a protective mechanism from your nervous system to protect you. When the nervous system feels threatened or feels like it's in danger, the nervous system sends out a protective mechanism, which is pain, right? There's other protective mechanisms in the nervous system. When it feels threatened, it could be heart palpitations, or it could be dizziness, it could be lightheadedness. When you have hypermobility disorder or you have EDS and your joints are loose or they're subluxing, the nervous system is getting all these danger signals. And of course, it's going to create pain to protect you. The brain begins interpreting normal movement as potential threats and potentially threatening. This doesn't mean that the pain is made up or the pain's in your head. It means the nervous system is becoming more sensitized. So that's why two people with the same degree of hypermobility may have very different pain experiences. It's all about the nervous system, and it's all about the nervous system interprets those sensations and if they interpret them as dangerous or safe. So someone whose nervous system that is interpreting these signals as dangerous are going to experience more pain, and maybe someone whose nervous system is not feeling threatened or not feeling in danger, there may not be pain associated with some of the hypermobility. What makes a difference there? Think about it. If you got a good night's sleep, you're not under any stress, you're not really scared about injuries or long-term consequences of this disease. Maybe you have good doctors, everything's going really well at home, you like your job. Your nervous system is more in that parasympathetic state, and you're less likely to have an active pain response. When you're really stressed out, you didn't sleep well, you're not eating well, you hate your job, you're having problems at home, Maybe you went through some stressful life changes. Then your nervous system is more in that sympathetic state and it's more in that fight or flight, and you're more likely to have symptoms. We can't control the hypermobility totally. We could do some stability exercises, but we can't totally control the way that your collagen is made in your body and the elasticity of your tissues, but we can control the amount of stress that you're under or your situation, or if you're doing breathing exercise or getting proper sleep. And that's what we're going to go into when we talk about the physical therapy approach to treating these conditions. Another thing I want to talk about is the language that we use. As physical therapists or physicians, the way we talk to patients and the way we talk to people, we could really scare them. And then basically, a lot of times, I've been doing some research on EDS before this podcast, and I've been reading a lot and I've been listening to other people. And I hate it when they say, there's no cure for EDS. You don't have to say that, right? Maybe in the semantics of not being a curable condition is something that was told to you. But you know what? You could do things to manage it, and you could handle your stress, and you could deal with your pain, and you could stabilize your joints. And there are plenty of things that you could do. Well, maybe there's not a magic cure, but there's plenty of things that you could do to improve the quality of your life and make you a lot more comfortable and make it a lot more comfortable to live with hypermobility or EDS. Let's talk now about the physical therapy approach to treating someone who has EDS or someone who has hypermobile EDS or hypermobility spectrum disorder. What actually helps here? The first thing we're going to do is rule out the red flag. The biggest red flag is upper cervical instability, especially in patients who are coming to see me with headache or migraine. We have to rule out upper cervical instability because that could be really dangerous. And usually, if you have a diagnosis of EDS or hypermobility, you've seen either an orthopedic surgeon for your neck, or you've seen a neurosurgeon, or you've seen a neurologist, rheumatologist, and they've probably done some x-rays to rule out cervical instability. We're ruling out red flags. That's really important for physical therapists to do before we start loading and treating, increasing or starting strength training programs with people who have EDS. Progressive strength training is probably the single most important intervention. And by progressive, we mean we're increasing load, but very slowly, right? Because we want to increase the load at a level where the tendons and the ligaments could adapt to the stresses placed on them as the muscles are growing and as the muscles are hypertrophying or growing. Hypermobile people love to stretch, surprise. And if you're listening to this podcast and you're hypermobile, you know it, right? You love yoga and you love to do flexibility and you love to do splits and you love to stretch your hamstrings. Everyone who's hypermobile loves to stretch their hamstrings. You don't need to stretch your hamstrings. They feel tight because those muscles are always firing to try to stabilize. And the reason that people are hypermobile, love to do yoga and splits and stretch their hamstrings and do trapeze and certain types of gymnastics is because they're really good at it. When you're really good and successful at something, of course you want to do more of it. Like, you're the best person in your yoga class. You could do some of these yoga poses that other people can't do, and you get into them really easy. But is that the best thing to help you stabilize your joints? We know when you're hypermobile, yoga's fine. And doing like splits and doing some of those things are okay. Like, if you really want to train that way and you enjoy it, go ahead. I'm not going to stop anyone from doing yoga, but you don't have to go to the very end range and you don't have to go to that stability. The more important thing, there's a lot of stability in yoga and you could do stabilization exercises, but strength training and stability training is really the most important thing. Since ligaments provide less passive support, the muscles become your dynamic stabilizers. The ligaments can't really do their job to support the joint. The muscles have to work extra hard to stabilize. We want to make sure those muscles are super strong because strong muscles help protect the joints. Tendons, they adapt to muscle strength. You can't grow tendons. Tendons are the tissue that attaches the muscle to the bone. When the muscles grow and get stronger, Tendons get stronger over time by adapting to the stronger muscles. So you can't do anything specifically to strengthen tendons, but strengthening muscles over time also strengthens the tendons and makes them less likely to become issues or have pain. But when you're doing that, you want to make sure you're slowly increasing that load to allow the tendons to adapt. Otherwise, we do see some tendinitises, and a lot of people who have hypermobility have a lot of different tendon issues. And one day they'll come in with Achilles tendon pain, and then they have elbow pain, and then they have patella tendon pain. And I feel like to avoid that, you got to really progress the strengthening really slow. So when we talk about strengthening, we're really going to focus on the glutes, focus on the core, rotator cuff, any of these muscles that stabilize. Even like thinking about the hands and fingers, if you have hypermobility of your hands and fingers, you're going to do really strengthen that grip and strengthen some of those small muscles in your hands. We're also going to strengthen muscles around your foot and ankle to avoid some of those ankle sprains, and definitely those deep cervical flexor muscles, the deep neck muscles to help stabilize the spine, especially if you have instability of that upper cervical spine, which becomes dangerous. I use a lot of balance boards, and I use a lot of different balance board, wobble boards, Bosu balls, vibration, anything that really helps all these muscles kick in to help you stabilize. The next type of training is building endurance. Not only do your muscles have to be strong, they have to work for long periods of time. Like you have to be able to sit for a long period of time, stand for a long period of time. And then a lot of people with hypermobility fatigue very easily. We try to increase walking, cycling, swimming, elliptical. Any cardiovascular fitness activity is going to help regulate the nervous system, is going to help build that endurance and build the muscular endurance. But the key here, as always, is that slow, gradual progression. The next thing we're going to work on is balance and proprioception. Proprioception is the ability for your joints to know where they are in space and the stability of the joints. Many people with hypermobility have reduced joint position awareness and decreased balance. So we're going to do exercises like single leg balancing, tandem balancing, which is one foot in front of the other, any type of dynamic balancing, maybe standing on one leg and swinging the foot forward and back, or tapping your foot to the front and to the side and to the back. We're going to do a lot of functional reaching, walking on different surfaces, standing on different surfaces, balance on surfaces with your eyes closed, with your eyes open, moving your head. This is where we get into some vestibular exercises also, really working on balance exercises to help stabilize those joints. Also, I do a lot of step ups and stepping exercises really to help people stabilize. These are all going to help people improve their confidence, improve the movement quality. Another thing that I really emphasize with people who have hypermobility is avoiding going to end ranges of motion. And this is what I talked about before during that yoga class, right? You may be able to palm the floor or get into these poses where your joints are all twisted around, but you don't have to go into those end ranges of motion. Do yoga and stop somewhere in the mid range, just hold it. Just holding that pose, not at the end range, is going to help you stabilize the joint. Think about yoga as more of stability exercise rather than really trying to stretch the mobility and stretch your range of motion, because you already have that range of motion. Just because you could move further doesn't mean that you should. And many people with hypermobility spend a lot of time standing with locked out knees or hanging on their ligaments or extending their elbows, hyperextending their elbows into extreme positions. But what we want to emphasize is controlling that motion and not just going into these weird motions where you're really hypermobile and your joints are moving into these positions, but really going into them slowly and controlled and using your muscles. You want to be within a comfortable, when you do all your strength training and you do all this balance training, you want to be in comfortable ranges of motion and really work on that stability and feel the muscles doing the work, because you don't want to be leaning on those ligaments. With EDS and with hypermobility spectrum disorders, we're going to get a lot of flare-ups. So as a physical therapist or trainers that see clients with EDS, we see a lot of flare-ups and you have to manage them. And a lot of times the flare ups are discouraging because they hurt, or their tendons might be swollen, or their joints might be irritated, and they're in a lot of pain, or they don't want to do anything. But I feel like bed rest and not doing anything is never the best idea. The key here is staying active. You don't have to force through intense pain or force through inflammation or tendonitis, because these symptoms often fluctuate. And you may have a tendon issue and some tendon pain or joint pain one day, and a couple of days later, it might be fine. So it doesn't necessarily mean you're causing damage just because you have pain in these tendons. So when symptoms do increase or you get a flare up, you want to reduce the activity temporarily, but don't stop moving altogether. You could always do some gentle walking, easy strengthening, breathing exercise. Make sleep a priority during flare ups. Gradually build yourself back up. I always tell people, hey, take an extra day off from your strength training, but then go back to it. Maybe go back to it, but a little bit lighter. And it's a marathon, not a sprint. We have to go and you have to strengthen, and it takes time. And when you have a flare up, it doesn't mean that you shut it down for 2 months. You take a day or two off, and then you go back and you find a way to strengthen yourself that's relatively pain-free or low level of pain, because it's really important to strengthen these muscles when you have hypermobility. The goal here is pacing, not avoiding movement. So I never tell people to stop exercising, and prolonged bed rest is never a good idea for anything anymore. All right, now let's talk about the nervous system, right? The nervous system, the autonomic nervous system, one of my favorite topics to talk about. And this is really where the pain comes. While we can't change the collagen we're born with, or we can't change the mobility or the hypermobility of your ligaments, we can influence how the nervous system responds. People with Ehlers-Danlos and Hypermobility Spectrum Disorder may need more analgesics at the dentist because the loose connective tissue doesn't hold the medication as well, and they may need more medication. This is an interesting statement because I see a lot of these patients that come in and they have different pain sensitivities. Oftentimes I hear stories that, hey, the dentist gives me Novocaine and then it doesn't work and they have to give me like 3 or 4 shots of that. Or I've often heard stories of people waking up during surgeries because the anesthetic wore off or the anesthesia wore off. A lot of times, because of the looseness of the collagen, it doesn't hold that medication as well. Knowing this is why it's important to go to doctors or dentists that are aware of what hypermobility is and what EDS is, and make sure that they know that they're giving the appropriate medication. Because now when we're talking about the nervous system and we're talking about pain, obviously when you have intense pain in your tendons or in your joints, you can't breathe it away. But some of these strategies are going to help calm down the nervous system. And if your nervous system is more calm, pain doesn't hurt as much, and you're less likely to have a protective response or an increased flare up. Things that may help calm the nervous system down: some paced breathing or some heart rate variability training, some biofeedback, meditation, yoga nidra, mindfulness, somatic tracking, pain reprocessing therapy, and progressive exposure to things that you're afraid of. These approaches are going to calm that nervous system down. They're not necessarily going to fix everything, but they're going to get your nervous system in a position where it's less likely to be protective and less likely to have an increased pain flare up. These are going to help reduce unnecessary protective response from your nervous system and improve your confidence with movement. Some of the frequently asked questions I get are, should I stretch? Which I've talked about this several times throughout today's podcast. If you're already super flexible, aggressive stretching into end range usually isn't going to be helpful. Although we talked about that people like to stretch, right? If you really enjoy stretching and it's something you really like to do and you like to get into maybe some yoga poses or stretch your hamstring, go ahead, stretch your hamstrings, but don't do it aggressively. Go to you feel a little bit of mild tension and just hold it there. You could still get the sensation of stretching, but don't overdo it. The next question is, can I lift weights? Of course, you could lift weights. That's one of the most important things that you could do. Strength training is the most effective treatment for hypermobility and for EDS, as long as it's progressed gradually and performed with good techniques. The next question I get a lot, will I always have pain? No, not necessarily. Some people could have EDS and could have hypermobility and have a ton of pain. And some people could have the same exact diagnosis and not have any pain at all. And that pain is definitely temporary and it fluctuates. If you learn how to manage it with the strategies that I've discussed before, like somatic tracking, pain reprocessing, mindfulness strategies, breathing exercises, your nervous system will be in a better situation to tolerate that pain. And then, yeah, you could definitely manage the symptoms with all of these strategies. The connective tissue may not change, but your function and quality of life absolutely can be helped throughout this. The most important message that I want to leave you with today is that hypermobility doesn't mean that you need to be afraid of movement. The goal of this program isn't to make you less flexible. It's to help you become stronger, more controlled, and more confident within the body that you have and within the motion that you have. This means gradually building strength, improving body awareness and coordination, increasing your tolerance to activity, and finding the right balance between protecting irritated tissues and continuing to move. Progress may take time, and strength training is going to be slow, and there are going to be setbacks and flare-ups along the way, but with the right approach, you could build a body that's stronger, more resilient, and better able to handle the things you want to do. And the key here, again, like, no one wants to have pain, but the key here is being able to live with Ehlers-Danlos and hypermobility and be able to do the things that you enjoy in life. And let's get you back to doing that stuff, and let's take the focus away from the pain and bring it more on to how could I get myself to do these things that I really enjoy in life. In closing, thanks so much for listening to another episode of the What's in Your Head podcast. If you found this episode helpful, please consider subscribing and leaving a review and sharing it with someone who may benefit. If you're looking for more education on persistent pain, dizziness, concussion, headaches, vestibular disorders, nervous system regulation, you could visit painanddizzy.com. And then if you want to learn more about dynamic sports physical therapy, and if you're in New York City and you want to come in for an evaluation and some physical therapy treatment, you could visit us at dynamicsportspt.com. Until next time, keep learning and keep moving. And remember, understanding what's happening in your body is often the first step to feeling better. Thanks for listening, and I'll see you on the next episode of What's in Your Head, Tools for Pain and Dizziness.